Okay, moving systemically. What about liver and GI function? What are the key markers telling us about liver health?
For the liver, we often start with serum bilirubin. As we mentioned, it's a breakdown product of old red blood cells processed by the liver.
Hmm.
If it builds up, it causes jaundice, that yellowing of the skin and eyes. Elevated bilirubin can point to different problems depending on the type. Increased red cell breakdown,
Yeah.
prehepatic, liver cell damage like hepatitis or cirrhosis hepatic, or a blockage preventing bile flow like gallstones, post-hepatic. We also look at serum proteins, mainly albumin and globulins. Albumin is the most abundant protein made by the liver. It's vital for maintaining fluid balance in your bloodstream, what we call oncotic pressure. Low albumin can lead to swelling, edema, and can indicate liver disease, kidney disease where protein is lost, or malnutrition. Globulins have various functions, including immune roles. The albumin globulin AG ratio is sometimes looked at too.
And then you have the liver enzymes, ALT, AST, ALP, GGT. How do these help? And you mentioned something interesting about the STALT ratio.
Right, the liver enzymes. Think of them as indicators of liver cell stress or damage. When liver cells are injured, these enzymes leak out into the blood. ALT, alanine transaminase, is considered more specific to the liver. AST, aspartate transaminase, is found in the liver, but also heart, muscle, kidney, brain. ALP, alkaline phosphatase, is high in liver disease, especially involving bile ducts, but also in bone disease. GGT, gamma-glutamyl transferase, is sensitive to liver damage, particularly from alcohol or bile duct issues.
So the ratio.
Yes, the AST-ALT ratio, sometimes called the Doritas ratio. This is where it gets really interesting for diagnostics. In many types of liver injury, ALT is often higher than AST. But in alcoholic liver disease, the pattern often flips, and the AST level is significantly higher than ALT, typically a ratio greater than 2.1.
Wow, that's specific.
It can be a strong indicator, yeah.
Hmm.
Also, looking at GGT and ALP together can help figure out if elevated ALP is coming from the liver or from bone, so the patterns are really key.
Okay, next up, renal function. The kidneys are our filters. What labs tell us how well they're doing their job?
The two workhorses here are BUN, blood urea nitrogen, and serum creatinine. BUN measures urea, which is a waste product from protein breakdown in the liver. The kidneys filter it out. High BUN can mean kidney damage, but also dehydration or even high protein intake. Normal is typically around 320 milligol. Serum creatinine is a waste product from normal muscle wear and tear. It's produced at a fairly constant rate and is filtered out very efficiently by healthy kidneys.
So creatinine is a better kidney marker.
It's generally considered a more reliable indicator of kidney function, specifically the glomerular filtration rate, GFR, which is the best overall measure of how well the kidneys are filtering. Normal serum creatinine is roughly 0.5 to 1.2 milligdl for adult males, slightly lower for females. As kidney function declines, creatinine levels rise because it's not being cleared effectively.
Now, you mentioned the BUN creatinine ratio earlier. What's fascinating about how that ratio helps pinpoint the cause of kidney injury?
Right, the ratio adds another layer of diagnostic insight. Both BUN and creatinine rise when kidneys fail, but BUN is also affected by other factors like hydration and protein metabolism because urea is reabsorbed by the kidney tubules while creatinine mostly isn't. So, if the ratio of BUN to creatinine is high, say greater than 20.1, it often suggests a pre-renal cause. The problem's happening before the kidneys, like dehydration, heart failure reducing blood flow to the kidneys, or GI bleeding increasing protein load. If the ratio is low, maybe less than 10.1, it might point more towards intrinsic kidney damage, like acute tubular necrosis, where urea reabsorption is impaired. If the ratio is sort of normal, 10-20.1, but both BUN and creatinine are high, it could be post-renal and obstruction after the kidneys, like kidney stones or an enlarged prostate blocking urine flow. It helps narrow things down quickly.
Okay, that's clever. Finally, in this section, serum electrolytes, the body's balancing act, sodium, potassium, calcium. Why are these seemingly tiny numbers so critical?
Oh, they are absolutely critical. These electrolytes conduct electricity in the body and regulate nerve and muscle function, hydration, blood pressure, and pH balance. Sodium is the main electrolyte outside your cells. It's key for fluid balance and nerve signals. Normal is about 135, 145 millimole. Too high, hypernatremia, or too low, hyponatremia, can be caused by many things, from dehydration or excessive water intake to kidney or hormone problems.
And potassium. You said the range is very narrow.
It's extremely narrow. Potassium is the main electrolyte inside your cells. The normal range in the blood is tiny, around 3.5 to 5.0 at Barkle. We really have to emphasize its critical role in nerve function and especially cardiac muscle function. Values even slightly outside this range can cause dangerous heart rhythm disturbances, arrhythmias. That's why potassium levels are watched so closely, particularly in hospitalized patients.
Wow.
Calcium is vital for bones, teeth, blood clotting, muscle contraction, and nerve function. Its levels are tightly controlled by parathyroid hormone and vitamin D. And then there are others like magnesium, chloride, phosphorus, plus important trace elements like iron, which we assess with tests like ferritin and transferring copper, zinc, all playing vital roles in tiny amounts. The balance is intricate. Okay, let's shift focus now to tests that help pinpoint really critical conditions, starting with cardiac disease markers, especially for diagnosing a heart attack or myocardial infarction, MI.
So when heart muscle gets damaged, say during a heart attack, specific things leak out that we can measure in the blood.
Precisely. When heart muscle cells die due to lack of oxygen, their contents, including specific enzymes and proteins, spill into the bloodstream. Measuring these gives us evidence of that damage. The most recommended biomarkers now for diagnosing an MI are the troponins. There are 3 subunits, I, C, and T. Troponin I and troponin T are virtually specific to heart muscle, making them highly accurate.
How quickly do they show up?
They start to rise within about 2 to 4 hours after the heart muscle injury begins. They typically peak around 10 to 24 hours, and importantly, they can stay elevated for quite a while, up to 1 to 2 weeks. This long window makes them very useful for detecting an MI, even if someone seeks help a bit later. They can also give an idea of how large the infarct, the damaged area, might be.
Are there other markers used besides troponin?
Yes, historically other enzymes were key and sometimes still provide context. Creatine phosphokinases, CK, is an enzyme found in muscle. The CKMB isoenzyme is much more specific to heart muscle. CKMB rises within about 3-6 hours, peaks earlier than troponin, around 12-24 hours, and returns to normal within 2-3 days. So it gives a shorter window view. Lactate dehydrogenase, LDH, was also used. There's a specific pattern where LDH1 becomes greater than LDH2, the flipped pattern, after an MI, but it rises later and stays elevated longer, similar to troponin. Less specific, though. SGOT, which is the same as AST we discussed with liver tests, also rises but is not specific to the heart. And myoglobin. It's not an enzyme but a protein found in muscle. It rises very early, maybe within 1-2 hours, but it's not specific to the heart at all. Any muscle damage can raise it. So it's more useful for ruling out an MI very early if it's negative. The key is often the pattern of rise and fall of these markers over time. Myoglobin first, then CK-CKMB, then troponin and LDH peaking later and lasting longer.
Okay. Beyond the immediate crisis of an MI, the lipid profile is crucial for assessing long-term heart disease risk. So what does this panel tell us? LDL, HDL, triglycerides? What does it all mean?
The lipid profile gives us a detailed look at the fats or lipids in your blood. It typically includes LDL cholesterol, often called the bad fat or bad cholesterol. LDL particles transport cholesterol from the liver out to the cells. High levels are strongly linked to the buildup of plaque in arteries atherosclerosis, which increases risk of heart attack and stroke.
Right, you want that low.
Generally, yes. Then there's HDL cholesterol, the good fat. HDL particles act like scavengers, picking up excess cholesterol from the tissues and arteries and transporting it back to the liver for removal. Higher levels are generally considered protective against heart disease. Triglycerides are the main form of fat stored in the body. High levels can be associated with increased risk of heart disease, but also other conditions like pancreatitis, hypothyroidism, liver disease, or metabolic syndrome. Total cholesterol is just the sum of all cholesterol types in your blood. Cholesterol itself isn't bad. It's essential for building cell walls, making hormones, vitamin D, and bile acids. A really key indicator often calculated from these is the cholesterol-HDL ratio, total cholesterol divided by HDL. A lower ratio is better, indicating a lower risk of atherosclerotic disease. It gives a good summary of the balance between the bad and good components. Now, let's talk about tests for infection and serology. This is often about detecting antibodies to figure out if you've encountered a specific bug.
So how do these antibody tests work in practice, and what are some key examples people might come across?
The basic principle is that when your body encounters an infectious agent, like a virus or bacterium, your immune system produces specific proteins called antibodies to fight it. Serological tests are designed to detect the presence or level of these specific antibodies in your blood serum. Finding certain antibodies can tell us if you have a current infection, if you had one in the past and are now immune, or sometimes if you have an autoimmune disease where antibodies mistakenly attack your own tissues. Importantly, results always need clinical correlation matching with symptoms and history.
Okay, examples.
Sure. For HIV, screening is usually done with an ELISA test. If that's positive, it's confirmed with a more specific Western blot test. But for monitoring HIV, doctors track the CD4 count, a type of immune cell targeted by HIV. Normal is 500 cells omega 3. AIDS is diagnosed when it drops below 200, and the viral load, which measures the amount of virus in the blood. The goal of treatment is to make it undetectable, usually 50 copy as MLO. For hepatitis B, the key marker for active infection is HB-Sag, hepatitis B surface antigen. It shows up 110 weeks after exposure. If it persists for more than 6 months, it indicates chronic infection. Anti-HB's antibodies, on the other hand, indicate immunity, either from past infection or vaccination. For typhoid fever, the older Weidel test looks for agglutinating antibodies against Salmonella typhi antigens, ONH. Rising titers, especially for the O-agglutinin, usually 1.160, suggest active infection, while H-agglutinin can persist after infection. Newer tests are often preferred now, though.
What about serious infections like sepsis?
Right. For suspected bacteremia, bacteria in the blood, or septic shock, a whole panel is usually run urgently. This includes a CBC, looking for high or very low WBCs, changes in differential, platelet count can drop, PDTTT, checking for clotting abnormalities like DIC, disseminated intravascular coagulation, electrolytes for dehydration, acidosis, glucose, often high, plus renal and liver function tests to assess organ damage caused by the infection.
And finally, in this section, tumor markers. These sound important for cancer, but what's their actual role and what are the limitations?
Tumor markers are substances, often proteins, that can be found in the blood, urine, or body tissues. They might be produced by the cancer cells themselves or by the body in response to the cancer. Their potential roles are quite broad. They can be used in screening for certain cancers in high-risk individuals, though this is limited, helping diagnose specific types if a biopsy is difficult, staging the cancer, assessing its extent, determining a prognosis, monitoring how well treatment is working, and detecting recurrence after treatment.
Okay, which markers are common?
Some key examples include alpha-fetoprotein, AFP, which can be elevated in liver cancer, testicular cancer, and some ovarian tumors. Beta-human chorionic gonadotropin, beta-HCG, is known as a pregnancy hormone, but it can also be a marker for certain gynecological and testicular tumors. Cancer antigen 1929, CA1929, is associated with pancreatic and bile duct cancers. Carcinoembryonic antigen, CEA, is often elevated in colorectal cancer, but also other cancers and some benign conditions. Prostate-specific antigen, PSA, is widely used for prostate cancer screening and monitoring, though it's controversial due to potential overdiagnosis.
So what's the important nuance or limitation?
The crucial thing to understand is that tumor markers are often not specific enough for diagnosis on their own. Many markers can be elevated in benign, non-cancerous conditions, too. For example, CEA can be high in smokers or people with inflammatory bowel disease. PSA can be elevated by benign prostate enlargement or infection. This lack of specificity means they aren't great for general population screening for most cancers. Their real strength often lies in monitoring patients already diagnosed with cancer. A falling level might indicate treatment is working, while a rising level could signal recurrence, often before it's visible on scans.